Hey, and welcome back to Soaring Profits Thursday night, 9 p.m., where we talk to interesting, exciting people from our community and the communities around us, and also as far away as Brazil, which is fun. Uh, Tonight, we have a very special guest. He's a professor at Durham College. This is John. He was a public service for the Ministry of Health. He worked as a director in the long-term care program, the Trillium Gift of Life. He worked in the Central East LHIN, which I don't know what that is, but I'm sure
I'll
he'll
tell you
tell
about it. Yeah.
us. John, he was also the hospital funding policy lead for Ontario and was the Ontario negotiator for inter-provincial billing. All of
Right.
that stuff. I'm sure you'll explain. This is more in
Yeah.
Pat's wheelhouse than I have ever been in my whole entire life.
Hmm.
So what happened was John and I are both in the same running club that I talk about all the time. You guys met Dave. John also is coached by Dave sometimes, and
Right.
we've been running off and on together. And he's told me a lot about what he teaches. And like as you guys know, I'm very interested in psychology, and I'm very interested in how people work together with each other. And a little bit of what he discussed with me is work ethic and how he teaches students work ethic. And I got pretty excited about that because I'm not sure that young people, I know myself, my work ethic came from my dad, but he was old school. I'm not sure now what that looks like. So, John, how about you give us as Pat always says, your little pitch about what you do?
Okay. Well, that's a heck of an introduction. Um, I did all those things. They do sound more impressive than they actually are, though. So I was the interprovincial billing negotiator. We used to get to go to Ottawa, and we would sit around these large rooms, formal rooms with linen tablecloths, and you have a little flag of Ontario, and you have this really nice banner with the symbols of Ontario, and above you in a circle were interpreters. So you had a headset and microphone, and they had lights on it. So you had to take turns, and everything you said was recorded and part of the official record of our interprovincial relationship. So it's a pretty dry subject, but as you probably know, if you go to another province, we have a universal healthcare system based on these five principles from the Canada Health Act, going way back to 1957. And as an aside, my dad used to provide medical services to some of the bands in Lake Winnipeg. There's a whole number of islands, and the islands have different bands in them. Before we had the Canada Health Act, as a young physician, he used to provide medical services to this band. And actually, to help them even further, he started up and supported a local hockey team, the Altona Maroons, is there, and they're still now a team, and he created that with other people as well. You can't take the entire credit for it, but created this hockey club so we could get some of the young men in these bands involved and outside of their community and doing these other things. And in return, because there's no compensation for that, they gave them these Hudson's Bay blankets, and we still have these Hudson's Bay blankets that they exchanged. He wouldn't have taken anything. He didn't want to take anything, but in terms of them honoring him, he accepted these gifts, and
Wow.
they're in the family. So that's a big aside. But so he was a physician, and I think that was sort of inspiring for me. I got involved in the health policy administration side, and worked in the Ministry of Health for 30 years. And one of those things was interprovincial billing. So yeah, if you go to another province, because the Canada Health Act 1957, you get coverage. It's universal. It's portable.
Mhm.
And there's a 3 month period where that province gets to bill back any services they provide to you. Right, you got to wait 3 months. You're still covered. So we have to work out this deal where between the provinces, where how much are we going to charge back? So it's a very dry technical discussion. And also, certain provinces are exporters of healthcare, like you have Alberta
Right.
and Ontario are exporters of organ transplant surgeries. Like not every province is so highly specialized,
Right. Right.
and you need a huge concentration of services. So that's Ontario and Alberta. So we have to work out. So how much are you going to charge us for a liver transplant for this person coming from Nova Scotia?
Right.
And it gets to be quite a bun fight sometimes between the provinces. But
Yeah,
At the end of it, we go out and have fun, have a drink and have dinner in Ottawa.
Right.
when my daughter first went to Halifax, Nova Scotia, she was still technically an Ontario citizen because she was going there for school, but she had to get some work done in a hospital, and it was funny because some of it was covered by Halifax and some of it was covered by Ontario, and she had to like kind of mitigate that with them all, like phone Ontario, and so. But I didn't know all that. I just assumed healthcare was healthcare was healthcare. It didn't matter where you were in Canada. But it just makes sense because we have OHIM. So it's Ontario, right?
Yeah.
But I've never really thought about it. That's so interesting.
Yeah, that goes back to 50s. That's one of the things that makes Canada so unique. And it's kind of it's hard to comprehend why the Americans do not understand the benefits of universal health care and the benefits to society and the health of your population, regardless of your income level, because it's absurd the amounts of insurance that they have to pay. They have some areas in the United States have worse health outcomes in third world countries. There are places I don't want to name any particular country, but in the Mississippi Delta area, for example, their birth weights and their just basic third world diseases exist in some of these places in the United States because they do not have universal health care coverage. So they have emergency care. So, for example, you don't have prenatal care, but if on an emergency basis, you can have a delivery, and it's done through as an emergency service. But you don't have any prenatal care, you don't have any postnatal care. That's it. So it's not surprising that you have some of the worst health outcomes in some of these areas in the United States, and it's because of their strange fixation with the free enterprise and minimal government involvement and sort of fear mongering that somehow universal health care is this socialized health care. And it's not that at all. It's not that at all. And they're especially stubborn about that. So that's another wild digression. But, in healthcare, interprovincial billing, that was part of it. That was kind of fun to do. And you get to see the dynamics that play out between the different provinces. Some of them are quite wealthy, like we're quite wealthy in Ontario. And then you're dealing with Quebec. And so we have headphones and interpreters on, but they are bound and determined because of their uniqueness. And they are unique. There's no question about that. Are not the most cooperative partners in this universal healthcare system that we have. So we always challenge, and this goes back to what I teach and why I teach and what I try to get across. The easy conversations, those easy days at work, they're nothing. There's no point talking about that. And I was just telling my students this yesterday in a course I teach. I developed a course on interpersonal communication and group dynamics. And I said, I'm giving you the impression that work is a disaster all the time. But there's no point in talking about your good days. So maybe you'll be lucky. Maybe you'll skate through your whole career and hardly have any problems. But we're going to talk about those things that do come up. And if we talk about them here now for the first time, you'll be able to handle it better. So we're going to go through it. So I get a lot of students checking out on that because it doesn't sound real. And other students really do like it. And like in any course, there's a bell curve of where your students are at. So, I try to make them be as engaging as possible because this is something that their ability to handle those difficult conversations at work and the difficult people is what's going to be the difference between their success and failure to a large extent at work. How to keep cool, how to survive and manage under stress and not get yourself in too much trouble, to maintain what I call your development status at work, where you're a person that they value and they want to invest in you and they want to develop you, right? At developmental level at work. And if you can hang in there, then you'll move up to a high performer and maybe to a management category. So my mission really is to, prepare them for the workforce. And I never had, I don't know about you two, but no one ever told me this stuff when I was going to school. It's just, there was no course that was anything like this. And I think it's a huge gap. And the students would tell me that too, that nobody tells them this. I do organizational design and structure. Like, this is where you are in the organization. You have a role. You stay within your role, and you have to behave within your role, and it doesn't diminish you as a person. It actually is something that's very admirable, that you understand your role and you're prepared to fulfill your role to the best of your ability. And if you can continue to do that, your role will expand, and they'll have more trust in you. You'll end up with more authority. You'll have a broader scope of work. It'll be much more gratifying and satisfying. So I was having that discussion with them yesterday about the importance of it.
I remember when I first started my career. So I worked in my first group home, and there was an old grizzled guy like this guy here. And I walked in all of 20, I think, maybe 19, somewhere in between there, knowing everything because I had just taken all the psychology courses and I knew exactly how to help kids, and troubled kids were my expertise. And I walked in and I proceeded to tell this old grizzled guy all of the things he was doing wrong. And he smiled at me and said, "James, you know what? I understand that you have a lot of knowledge, but none of that applies here. I'm going to tell you right now, we've tried everything that you're saying and we've narrowed it down, and this is what we're. But if you want to go try it, you go ahead." And then he just smiled. He said, "Your job right now for the next month is to listen. Your job is to not rock the boat. Your job is not to get involved. Your job is to watch, listen, and learn. It doesn't matter what knowledge you have, because you're on the ground now. You're in front of the, you're in the trench. And while you're in the trench, you need to listen if you want to stay alive and stay safe." And he was so right. Like my first day to like day 365, I was like a chicken with my head cut off because I had no idea what was going on. I was flying by the seat of my pants. All my education was out the window. Like I didn't even know how to apply it. Fortunately, I had a grizzled old man standing beside me, helping me out. He took my calls anytime I wanted. But without him, I don't even know that I'd still be in the career. Like,
well, haven't we just come full circle there, you grizzled old man? You're kind of
I'm a grizzled old man, and I'm teaching this one beside me.
That's it. So, John, lots to unpack in kind of the monologue there. Some things I agree, some things I very much disagree, and maybe we can unpack a few of those.
Yeah, sure.
Obviously, you have a kind of an intricate viewing and understanding of the system, like you were saying, you as you refer to it, kind of the drier things when it comes to the interprovincial aspect. But your viewpoint on our public system that has arguably fallen apart over the last 10, 15 years, do you not think that there's room for private payer systems to be established in our country at this point?
Well, they exist now. I don't even use the word system. We don't really have a healthcare system. So it's a false premise to talk about the system that has fallen apart. We have formal arrangements. We have division of powers between the provinces and Canada and the federal government. We have transfer payments for healthcare. But it's extremely loose, and it's up to each province to decide how to spend that money. There's no, it's not stipulated exactly what has to be provided. It's up to the provinces to do that. I heard someone use the term that what we have is a functioning non-system, which I think is a much better, more accurate description of what we have here in Canada. It does sort of function, but we kind of stagger along, and we fool ourselves. There's a great expression by a guy called Frederick von Hayek. Have you ever heard of him?
No.
He was a contemporary of Keynes, and he said there's a certain fatal conceit, and in fact, one of his books called The Fatal Conceit, about because we can manage small scale projects, we are able to therefore to manage large scale projects. But actually, as the scale changes on things, that it no longer becomes it's no longer manageable. And I think there's this fallacy around that you can, with more resources and more money, especially that's one of the worst things that happens, is you just shovel money into the problem, and you continue to have the problem. And I've been doing this for so long. We're still having the same conversation 30 years later about fixing the system. And you brought it up that the system is falling apart. I'm not sure. I've never been. I don't know anybody who honestly can look at it and say that We might have some gaps in the system. I hate calling it that, but there are things that we can do in terms of our efficiencies that we can do, and the things that we spend money on, and the follow-up and the performance. And we have gaps in the area that you work in, for example.
Right.
Spectrum disorders is not covered whatsoever, I don't believe. I think funding has been rescinded for that. So there's been a lack of sort of intelligence about what is the most effective treatment and the best way to deliver it. And to your point about whether there's a role for private pay, there actually is a role for private pay. We do have a Private Hospitals Act in Ontario, and we pay for them out of tax dollars. Mm-hmm. And there definitely is a role to augment the public system. And the argument against the public system, the private system partnering with the public system, is that it undermines the public system to the detriment of service provided to the public. That if the private sector grows too much, there'll be less support and less money flowing into the public system. So that was a theoretical argument. I mean, people at U of T who teach in health policy departments over there, that's what they'll tell you. But I think there's a huge role for recognizing that we have a very complex healthcare system and of many different moving parts, and we don't really fully understand how it works. Just like Hayek's comment, it's a fatal conceit to think we can understand all the pulleys and levers and how everything works and how everybody interacts, so that we can just go in there and fine tune it and change it like it's some sort of mechanism. And it's not. A true system like a car is a mechanical system, and it's designed and the parts work together, and they still break down. And our healthcare system is never designed that way. It just evolves over the last 100 years probably, or especially the last 30 years, where we've tried to sort of add things and take away things. We rarely ever take away anything at all. I mean, can you name a program that doesn't exist now, that did not exist before?
And I think that kind of goes to, the crux of, my viewpoint on this. And the profiteers out there have kind of heard me rant on our current healthcare kerfuffle, whatever you want to call it, here in the province of Ontario. And a lot of that goes back to is just bureaucracy. When you have a situation in which we're adding programs and then never ever remove said programs, the waste that is exponential. So I had a business here locally where we provided nursing services. I was partnered with a Trent professor, a local physician. We were growing this business, and we were the hot commodity at the time because we were a for private payer system before that was happening. So we were providing in-home services for seniors before that was happening. And that was an interesting concept because it was a very, I got told by my family members, like, you're some American Yahoo because you're trying to go with a for-payer system. But that allowed that industry to become something else. It grew and it blossomed and it provided needed services for people. And then we split and decided to go our separate ways in the business model. But that was revolutionary at the time. We were taking insurance-based coverage. We were taking private payer. We were doing all these things. My struggle is that if you are a Canadian citizen, whatever your financial needs are or your financial situation is, you should be able to get the care that you need, 100%. But I also believe that if you can afford it, you're leaving and going to a separate country. And that's a problem. In a first world country, we shouldn't see people going down and getting MRIs in Buffalo, 10 minutes across our border. That's a shame. And to me, that's very problematic. So to be able to institute those situations in this country, I think we're seeing that more and more and more. And I see the Conservative government here in Ontario transitioning quickly to what's going to be a two-tier healthcare system. And I think it's our system needs to lie down. It is all but there. When you're sitting in an emergency room for 8, 9, 10 hours for an ear infection with your child, or you can do a rocket doctor video conference like we're doing right now, and you're going to have a prescription in 5 minutes, I will certainly pay $40.
Right.
I know there's people that can't afford that.
Right.
But that is a copay that myself and anyone I know is willing to do. And that's free market. That will dictate where our system goes next, I feel. What do you think about that, John?
I completely agree with you. And there's an ideological.
Oh, that's it, folks. Good night.
I've always felt that way. And I worked, one of the other parts that you mentioned is my connection to long-term care homes, or homes for the aged and nursing homes. We typically think of them. And I work for the Ontario Long-Term Care Association as the director of finance for them. And they're a private pay model, and they are subsidized. These are like Extendicare. They're huge, multi-billion-dollar, publicly held corporations. They have operations in the United States, and there are many of them in Ontario. And they provide the majority of homes for the aged services in Ontario. And they have an exceptional track record. And it's because if they do not do well, they will be out of business. They will not have jobs anymore. They will have lost a lot of money. And so there's a huge problem.
How do we bring those invested parties back to the table? Where if we're up at your local hospital, doesn't matter where you are, anywhere in the province of Ontario right now, wait times are astronomical. How do we bring invested parties back to that negotiating table to pull the fat, to pull an efficiency model that goes back to some of the natural market tendencies?
Yeah, well, that's a great topic, and that's hotly debated. And I was involved in that for a long time, that exact issue. There are people, they're engineers, optimization experts at U of T, Dr. Michael Carter, and he'd be a fantastic guest. And he has his engineering students working on optimization models for the delivery of healthcare, specifically emergency care, because grabbing people and moving them through a system is an optimization problem.
Right.
And they have lots of ideas, but there's and if that engages the private sector, then, as long as it works and we're able to maintain a basic universal healthcare system without jeopardizing that, which is a concern of some people at the U of T, I can characterize them a certain way. And then you have people like Dr. Carter, who's saying, no, that doesn't really matter. We get better outcomes this way, right? And we can create a lot of efficiencies this way. So that is, and I was the manager for emergency room reporting and analytics at Cancer Care Ontario. No, not too many people know this, but Cancer Care Ontario was hired by the Ministry of Health to do all of their reporting and analytics for the wait time strategy and ER wait times, because the government at the time, this is going back to Smitherman, the opposition said, we don't trust your reporting. And there's a wait time strategy initiated by the federal government, and it was all across Canada. And there was concern that the Ontario government under Smitherman would just take this money and they wouldn't really do anything. They wanted a third-party person to look at it. So that was Cancer Care Ontario, which was great for them. And they're a fantastic group. They're very business-oriented. They're very analytical. And they had a lot of money, and they hired top-notch people to do the analytics and reporting. And it was third-party. It went through another separate validation process, and it was signed off. Some of the people who signed off on it are own large brokerages in Toronto. I can't think of his name right now. Michael Decter. Okay. You may have heard of Michael Decter, right? He owns LDIC actually, which is a brokerage in Toronto. It's a high-end boutique brokerage in Toronto. He was signing off on our ER reporting times, if you can imagine that bizarre so-called system that we have. So now here's the problem. Here's one of the many complex problems. We have changed what ER is. So when my dad was in a hospital and they had an ER department, the ER department, there was primary care and you were covered. You had a physician. The ER department was closed. It was not open. You couldn't just walk into the ER department. It was for emergencies only.
Right.
So they would get a call saying, oh, there's been an accident, open up the ER. They'd go in there, turn the lights on and get ready. They would treat those people and then they would close them. So who is responsible for the influx of people in the ER? Have we
would that be what we're looking at in the brain drain of the 90s, where we saw physicians that were saying, like, so for instance, I have an uncle of mine who's a physician in Virginia, was in the province of Ontario. He was an engineer first, then became a physician. So not really an intelligent fellow by any means, right? He's pretty
there's more than one of those around, actually.
Right. Those guys are crazy. Good for them. Yeah. I don't know why they chose medicine. They could have made way more money engineering, I'm sure. But this was a situation where for himself, he was running a family practice in a smaller community, a tourist town in Ontario. And
Yeah.
it was him and another guy. They were the two doctors for the whole community, 18,000 people approximately. And then on weekends, you never knew what you were getting with tourism. And he ended up, I believe at the time, it was right around $220,000 a year they were capped at. Now, with that, he had an office he had to run. He had a secretary he had to run. My aunt ended up being the secretary. You know, you've got a nurse. You've got all of these people that come into this. And when you're capped at X value, whatever it is, the market is going to dictate. If the doctor ends up making 500,000 or 700,000, his nurse has her hands out. I would like a raise. I know what you make. The office building is then saying, hey, they're doctors. We can charge them a little bit more. All of these things come into effect. Now, during the brain drain, and it's not my term, you know, for those of you that don't know exactly what I'm talking about here.
Oh, I know about it. Yeah.
Right. For those at home that are listening. So we saw a huge influx of our medical professionals pick up and leave Ontario specifically, but Canada as a generality, in regards to going and seeking a better paying financial future for their families, where there is no cap. And by cap, my uncle was in a position where he was basically done his service hours in August every year. Like, he had seen enough patients to cover his entire year by August. And the problem with that was, what do? You can't stop seeing people. People keep wanting to have babies. It all has to be managed. And that's a system. And again, we're talking about the system of not systems, but that was broken. And we saw an influx of medical professionals leave the province, and we weren't wise enough. Because I don't know if at the time we had, you know, the Ray days, we had the NDP that were in there, and making money is against their religion, I guess. I don't know what that was, but.
Well, that's part of the problem with ER is Bob Ray.
Right.
So
you brought up an interesting point. Like, now when I go to the ER, and I was just there recently for something, one of my clients needed something, but the whole room was full of people with the sniffles. Like,
so you could blame primary.
There was like one lady with a broken arm that should have been in like hours ago. She was like 80 years old. She had a broken arm. It was obviously broken. And she sat there for about 2 hours. And then all these like people with sniffles. There were so many people. I think COVID was a factor of that. But it just boggles my mind. Like, I guess because there's no doctors. But like you said, I didn't, when I was a kid, maybe it was before I was a kid. Was it that ERs were closed to, like, it would be the ambulance bringing people only, or?
Well, that's the 50s. You know, a lot has changed. So there's a lot of different touch points on there. I was well into my career in the 90s. I remember the myth of the brain drain. Now, people did leave, but if you track them, they came back because
you
they
did not like. You made a financial.
Oh well, yeah, we can cite individual cases, but on the aggregate, most of those physicians ended up coming back because the American system is not far from ideal as well too. So you have to, they're not capped. They have more potential of profit, but they're also open to huge liability claims, malpractice suits and claims. And the insurance is so high. So the overhead costs of those operations are extremely high, and you can be run off your feet. And a lot of them decide, this is really not for me. I'd rather just work a regular week and make my $150,000, $200,000 and have a normal life. And many of them actually turned around and came back to Canada after they got a taste of the American system. So the reason some of those, there's so much hypocrisy in politics, but there was a lot of hypocrisy, especially within the Bob Ray government, sort of a leftist, socialist type interpretation of how to deliver healthcare. And they portrayed the physicians. I was there, and this is how they talked. They weren't shy about it, that these physicians were these fat cat physicians, and they were overpaid, and they're making money and profiting off of the ill health and suffering of other people, right? It's just a classic scenario of deprivation that was very popular at the time, and it was promoted at the time. In fact, that was not true. That is not what is happening. Doctors were run off their feet. And then Bob Ray came along and started to clamp down on the number of seats, limiting the supply of doctors and affecting the profit potential and the compensation that they could get. So they were capped. You made that point yourself. Why would I continue to work?
Right.
And there's no incentive for me to work. I became a doctor because I want to practice medicine. Most people don't have the discipline, focus, and rigor to get through medical training purely on the basis of profit motive. Now, I've told this to physicians, they laughed at me. But those were cardiologists.
Right.
Now, if you're a cardiologist, you could be billing $100,000 a month just in the hospital, and you still have a private practice. So you can make serious money. And the cardiologists I knew were multimillionaires. Yeah. And I remember talking to one. I'm not going to bring up any names, of course, but
local guy.
Well, he's within driving distance of here.
Sure.
But I was talking to him in the hospital, and the cardiologists were very, very competitive with each other for cases because they get the bill.
Right.
And I was talking to him in the hallway once and said, "Why are you guys always fighting over patients?" Right? They're practically hanging by the door, waiting for the next patient to come in and to sort of jump on them. Like, well, they do have a system. They have a scorecard there, right? And you're on the list. And they would fight about this list all the time. And I say, "No, why do you guys always do that? Don't you make enough money? Like, what's the big deal?" And he looked at me like I was some sort of fool, and took pity on me. And he put his hand on my shoulder and he says, "John, you can never have enough money. My wife wants a second elevator in the house."
Right.
So, the profit motive. And these guys worked like crazy, and they weren't capped because they were specialists. They're cardiac specialists. They were allowed to do that. They weren't part of the primary care models. These other models that were introduced by the following government started with, I don't remember who came after Ray now. What was his name?
Harris?
Actually, it was actually with the Harris government that we started to see community health centers and primary care models. And it was the primary care models that really started to affect the amount of work and effort a physician would put into their work. When they started to try, I saw it, I was watching it happen. They started to go from being run off their feet and their patients going around like a turnstile, like over and over again to meet the demand. But they were being compensated. And now they had the same demands, but they were not being compensated. So they actually moved over to the primary care models. They were forced to move over to the primary care models. And they started working like regular people. And there's that huge surplus demand now that was created by this ideology that these primary care models will remove the profit incentive and they'll be more effective. The complete opposite happened.
Absolutely.
And then I'm circling back to...
Can you explain what a primary care model is?
Right. So rather than before primary care models, physicians would have a clinic. They'd have an office. A bunch of them would get together. They were privately operated, right? So there's another example of a private ownership. They were always private. I mean, you had nursing stations up north. And, we have federal nursing stations and services. Very, very few, very rare. Everything else was provided by physicians opening a business and buying a building, taking all the business risk, doing all the investing, borrowing money, hiring staff, the whole thing. They were a business.
Now this is pre-57, you're saying?
Oh no, that was pre-57, and it was pre-primary care models.
Okay.
So this idea started to infiltrate. The thinking of the policymakers and the public, and especially politicians who wanted to remove the evil profit motive and wanted to create these primary care models, and that you would have. So here's the more of the irony of the whole thing. If you wait around long enough, you can see how silly some of this stuff is. So they decided, okay, what we're going to do, we're going to solve the ER problem. We're going to remove the profit motive. We're going to create primary care models where you register as a patient. So now you are assigned to that primary care model, and you shouldn't use any other primary care model because that your primary care model actually gets a certain amount per person per year to retain you as a patient and to treat you holistically. So it sounds fantastic, right?
Yeah.
And that's a great idea, and that sort of became a dominant thought, but it wasn't really based on what was really happening, the real forces that were at play within the healthcare system. So a lot of these physicians said, well, that's great, actually. And we know some people through the running club who are physicians, and that's exactly what they're doing. In fact, they're so young that that's all they've ever known is I'm just going to punch in and punch out as a physician. I'm not going to do what my dad had to do, which was run like crazy, and you never saw him because he was always treating people. Right. And actually, he became a psychiatrist, and one of his specialty groups that he treated as a psychiatrist were other physicians who were run off their feet, right. Getting completely burnt out, sacrificing themselves for their patients. But all of that dynamic, which was portrayed as a greedy profit motive was taken away from them, and now they were moved into these primary care models based on some sort of false ideology.
Right.
And I have other family members who are physicians, and they're just infuriated by the introduction of this primary care model, which sounds great on paper, but actually removed a tremendous incentive. That's, Patrick, that's kind of your point, that we haven't engaged the forces of the private sector here and to use them as a complement to a public system. So you're in the primary care model. So now what happens? Now people no longer have access to their primary care physician the way that they used to. They have to go to ER to get primary care.
Yeah.
So you saw this happen. You saw it in real time. It didn't even take that long. That all of a sudden these ER problems were driven by the history of implementing primary care, and especially starting with the Ray government having to create much fewer medical seats, so you have fewer students graduating. They wanted to control the supply of physicians, and demonizing physicians because they were driven by this evil profit motive, and they just took away the motive to provide care, which is why they went to school in the first place.
So John, why would they want to control the number of seats that's educating doctors in the province?
Well, that has they were demonized, especially by the Ray government. You can see them talk about it.
And I kind of remember that they were saying that they were greedy and they were for too much. I remember that vaguely. I was young then, but
and I've looked at
wouldn't that play like into just market dynamics? If the supply and demand, the further you restrict the supply of X coming into the market, this case doctors, then the demand increases, and therefore the profitability of that greedy fat cat that you're labeling becomes exponentially higher.
Yeah, it was sort of this confluence of stupid ideas.
Socialism.
Yeah. Okay. It was ideologically bent.
Right.
So there's a couple of things going on there. So they were being demonized and sort of kicked to the curb, and we lost their engagement in the healthcare system, and it had this huge backlog started in the ER department. The ER is now basically primary care. You should not take your kid there because they have an earache, and that's why you end up waiting there for 6 hours. When the true ER cases, now they do, there's what's called a CTAS scale. They triage people as they come in there. So if your life is threatened, they will take you right in, and that's why you can wait 6 hours to get your earache looked after.
So John, we've talked a lot about kind of the figurative things. But where does this go from here? Like, where do you see 2030 with our healthcare system? Because again, you have an inside knowledge where here at Soaring Profits, we like to talk to individuals that kind of are able to pull back the curtain on certain aspects. We've interviewed some people that are, sexual assault survivors of the Catholic Church. We've talked to individuals that have, drug and alcohol. We've had individuals that are all kinds of different things where they're able to pull back a little bit. Our last one was a mainstream media broadcaster for years, and now she's doing addictions and health recovery. And her stories about mainstream media and what she refused to talk about and publicize. So we're really thankful when we get someone like yourself that has kind of that pull back the curtain type mentality.
Yeah.
So where do you see 2030 in the province of Ontario, or just in Canada in general, for our healthcare system?
Yeah, well, I'll just finish off my last point there. I got sidetracked. Why would they affect the supply of physicians? And this is where the confluence of bad decision making happened. The OMA licenses physicians, and the OMA plays this economic game with the government, and their advantage to restrict the supply of physicians, because then you can increase the price. Right. It's basic supply and demand economics. So they have an advantage for doing that. Well, that infuriates some physicians, and the OMA itself gets there's a lot of infighting going on there, of course. And the NDP had a natural ingrained distrust of physicians for a variety of reasons. And I think there's psychological explanations about why they portrayed them that way. So between the OMA and the NDP and this portrayal of these physicians as these and the role that profit played in that, which was all false, you ended up with a fewer supply of physicians actually being able to provide, and there you end up with backlogs within the healthcare system. So I'm not optimistic about the future at all. It's going to see the problem is politicians are on a 4-year cycle,
Right.
and they want to get reelected.
Yeah.
And healthcare is, it's such an important. It's a part of the Canadian identity, and we're very proud of it. And it is motherhood and apple pie kind of issue. And everybody's been sick at one point or another, and everybody has seen a doctor, and it's seen as their right. And there's always, because it is this sort of semi-functioning non-system. And I just, Ford is arguing with the feds right now today.
Mm-hmm.
And it's a constant issue. It always has been, going back to the very beginning of my career in '89, I think. It is never going to be, it's not something that can ever be resolved. There will be never a point where everybody will say, well, we got that figured out.
Right.
Yeah, let's just keep going. The healthcare system is perfect. When you get sick, and it takes you a while to get better, you are going to see that partly, if not almost entirely, as a failure of the healthcare system to cure you from something that's probably inevitable for you.
Right.
And it's not truly curable. So there's a natural interpretation or tendency to think to equate your own illness with a failure within the healthcare system. And it's never going to ever be resolved. This is why stuff that Dr. Carter is doing at U of T about optimization. You're never going to actually create this system where everybody's going to be satisfied and it's perfect and it's perfectly functioning. We don't even have the metrics to measure the system. Now, we implemented a lot of them for ER reporting. We measured how long it took a person literally from the door to walk over to get triaged, and how long it takes for them to get triaged, and then to get to see a physician, and from physician to treatment, and from treatment to actually exiting the building. We had these kiosks. That's what those kiosks do, right? You get so we were measuring everything, but that didn't change it, the fundamental dynamics. And then we provided incentives to the hospitals. If you could reduce the time between these different intervals, we would give you extra money. It was called pay for performance. Right. And it's probably still going on. So they were trying to, again, yet another irony within the healthcare system. They were now going to introduce the profit motive and pay these hospitals even more money to try to become more efficient. But you just get overwhelmed at the door because the primary care physicians are not as accessible as they used to be, because they've now been put into these primary care models. And I was at the meeting in Toronto at Queen's Park when this came up post-Christmas, and Christmas fell on a weekend. And this would be like 12 years ago now or so. And people were shocked and appalled and amazed that there was such huge waiting lines and backlogs in ER in Toronto. It was a catastrophe. It was an absolute disaster. And people were saying, well, we have these primary care models. You have a physician. You are registered with them. You have access to these physicians. What happened? Well, those, I mean, you can guess what the answer is. Those physicians who are not being compensated anymore now are enjoying the benefits of more or less normal life, not motivated to go above and beyond anything now, were not available and did not make themselves available on a Christmas weekend. So everybody had to go to ER, and everybody, that's a peak time of the year for people to get sick. Everybody's congested, everybody's stressed. And I sat there and I couldn't believe, like, are you kidding me? You guys can't see the connection here between what you have done through your policies over the last 20 years to sort of crowd out the physicians and their role in the healthcare system, providing services and going above and beyond. and doing it for free, essentially. My dad did that. I know that from firsthand experience. And all of his physician friends, we talked about this all the time. I mean, they dedicated their lives to medicine. And now they were being sort of like, no, you guys are, we have to control you. We have to do this, that, and the other thing to you because of the terrible, the usual socialized interpretation of provision of medicine. So it really backfired on them. So that's why I'm not terribly optimistic, because we now have these concepts and ideologies that are driving the system based on something that is very basically human, and it has a tremendous connection to the public. And they will never be at the point where the system actually works. We can make some small improvements. I mean, I think we've improved long-term care. I know about that more. We've improved the hospital funding model. I was the hospital policy lead for Ontario for a while, but we had a separate funding methodology unit, and they did their own thing. And I developed some hospital funding models for small hospitals. And it was about, sort of tweaking around the edges and trying to improve around it. So we have improved the way that we fund hospitals. They're much more population-based now. We have what's called integrated population-based funding models, variation. So there has been some improvements in there, but you'll never get to the point ever in healthcare where you can say, job done, we're good.
Right.
It's not the nature of that kind of service, and it will never be that way. And the politicians on their 4-year cycle will always be very eager to respond to, or appearing to respond to, this apple pie motherhood issue, and that we're going to provide everything for you and pat you on the head and send you away. And that's very cynical of you, I admit it.
Right.
But it happens all the time.
It's kind of exactly where I think anyone that has touched the system of late probably feels, where it feels like you're simply a number. Myself, I'm 36 years old. I don't have a family physician in our community. That's pretty wild.
Well, the supply.
Now I kind of understand it more, John. Like, thanks for explaining that to me, because like I remember when as a kid, everyone had a doctor. It was so easy to get a doctor, and now two things are happening, which is so I'm a big fan of the system, not system, only because people below poverty can't access anything unless, if we were in a private model, it would be harder. Like you said, there are some parts of America that their system is so flawed because there's not enough money in it. But there are friends at work that tell me all the time how their doctor's horrible, like how the doctor prescribes wrong, doesn't really talk to them, doesn't help them. Just
Karen's med school degree that she's working on.
But so I'm like, well, change doctors. And she's like, how?
Well, no. They've disengaged because they've been forced to disengage to a large extent. Not every single one of them, but by and large, that has been the trend. Yeah. Well, we've done, so there's some bright spots. In the nurse practitioner program was probably a good idea. I mean, they're just shy of being physicians, and they can't, they do prescribe.
Yep.
So they have a very
anything
large
other than narcotics, I believe. They have all narcotics are being done. But so like your basic prescriptions, that I would argue probably bogs down the system to a toll of 65 to 75% of your daily visits is little Timmy, little Johnny. Bumps here, bruises here, sniffles here. What do I do? Right. And that's such a deadly thing. John, I want to touch on this. I appreciate your view on the healthcare system, and I believe that we kind of came around where I think you agreed with me that we have some problems. So we'll kind of leave out for that for right now. But you were talking in regards to some of your financial things that you've done in your past. You manage your own personal finances and created some wealth for yourself. And one of the companies that I'm a pretty big shareholder in right now is called Palantir Technologies, and Palantir is doing projects as a software as a service. And one of the product lines that they offer is Gotham. And Gotham is doing exactly what it sounds like you guys have done, and amalgamating a number of different data entry sources to be able to streamline and print out information, whatever it is. It's going to be able to streamline thousands, millions of data points, being able to database them and be able to bring them in. And Palantir was pivotal in the COVID vaccine rollouts. It was pivotal in a lot of the stuff that we saw in regards to, the Gotham itself, its biggest project was COVID-19 vaccination rollouts, but it has a number of other project sets Another one they have is, Foundry. Gotham is the more police-based, spy-based, anti-terrorism, that sort of thing.
Right.
And these again, this is private sector. This is private sector coming in and providing tech solutions to governmental problems. And that goes back to that efficiency stuff. I was wondering if you had heard of Palantir Technologies before or not.
I've never heard of it. No. I mean, I understand the concept. Yeah.
Yeah. Very interesting. Very interesting. They are very not in the box. And I don't know what that means when it comes to Palo Alto based type companies. They left. They're now based out of Colorado because they said that we're just not going to deal with the big tech environment. They are very pro-Western ideology, which I think in the time and place where we are in the world right now, that's not a bad thing. Right. And it's very interesting company for yourself. Do you mind telling us a little bit about how you, what you did with your personal finances and how you kind of created some wealth for yourself?
Oh, absolutely. I think we could all learn from some grade 9 algebra.
There you go.
A spreadsheet.
Yeah.
It is not, there's been a great disservice given to us by the financial services industry and talking to us like we're children and saying, and just look at the commercials. I see them all the time. This is too complicated for you. You need our help. We're here to help you. We care about you. Right. They're just, it's packaged goods and it's really not that complicated. Money compounds over time.
Yeah.
You have a spreadsheet. You can make some assumptions. I've created many of these things. And if you do a simple budget, and I was separated and I was paying support and I had 2 young boys and I was working like crazy in Toronto. So I needed a plan. And after my divorce, I had nothing. And I knew how old I was. And I figured, well, that's all the information you really need.
Right.
Like you need a budget. You got 20 years.
I can extrapolate. Yeah.
I can do simple extrapolations.
Yep.
I can have a budget. I stick to the budget and learning how to. So that's one thing.
Yeah.
So that's very important. And that's very, very simple math. So it is not beyond anybody to be able to do that simple algebra, to figure that out and to have a budget and have the discipline to stick to it. So you are trading off some of your present for your future, because I'm not going to do something now in the present time because I'm going to defer that to some future point. And that what that future point equates to is that you get to retire earlier. So you're trading off your work now for an earlier retirement so that you can buy time for yourself. And there's nothing more important than having time.
See, John, I think that is such a linchpin aspect that people don't understand.
They don't.
Everyone thinks that this is their grandfather's, in the States, your IRA, or, the old man looking through the bonds in the newspaper going, what's the yield today? Right.
Right.
And this technology has made this seamless. It has made it so simple. Like you can fall down and be investing on a daily basis. And whatever that is, if you're in a situation where you're raising a young family, and I'm 36 years old, I have a daughter, I have a fairly decent income, I would argue. And I've set myself up to have passive income streams, right?
Yeah, me too. Yeah.
I just sit back and money rolls in every month.
Yeah.
And those situations are not abstract concepts to understand. It's simply implementing. So one of the big things that I try to talk about all the time, James, is all about the personal wellness. And I love it. It's so deep when you get down to finding and working on who you are and bettering yourself as a person. But if you can't sleep at night because you can't pay your bills, I don't care how much therapy you're going through.
Right.
You're done.
Right.
You're done.
Yeah.
And this sorry, John.
That's right. Yeah. People with money live longer.
Yeah.
I mean,
you eat better. You sleep better. Yeah.
Like
there's a high correlation. Yeah.
I'm a touchy-feely guy. I know a lot about psychology. I know a lot about like interpersonal relationships and helping people get goals and stuff. Knew nothing about money. In fact, money really scared me because I didn't understand it. I thought stock markets were like so complicated, not even worth getting. I remember arguing with people saying, "There's no way. Why would I get into stock markets? I have no idea what."
Oh yeah, you really ought to. It's not too late for you. Another key.
No, I know it's not, because Pat. That's what I'm trying to tell you. Pat took me aside. He said, "Okay, you're gonna get these passive income streams coming to you.
Yeah,
you're gonna set up your house in such a way that you're gonna get some passive income, and then you're gonna use that passive income to buy and sell stocks." And I'm going to show you how to do it using this fancy little app. and you can
Right.
do it. You can be as involved or
Yeah.
uninvolved as you want to be. So you can watch it
Exactly.
daily, see all the
Yeah.
graphs, figure out what's going to happen in the political climate and make a
Yeah.
choice, or you can just buy something and walk away from it. Either
Well,
way, you're
yeah.
probably going to make money if you make sound investments.
Right.
And
You need to get
the
it.
stuff that Pat's taught me is amazing because of that.
Yeah.
It's not rocket science at
No,
the end
it's
of the
not.
day.
Well, it's a dimension to your life that should be part of your life and every
Yeah.
single day of your life. So if you pay attention to your finances, you can then start paying attention to the economy, politics, history, global events,
Yeah.
political movements, everything that's going on is connected to and sort of reflected within the state of the markets. So as you know, it's that you're fixated on finances, but that it's a door that opens you up to everything that's going on in the world. You become much more knowledgeable and aware of what's going on. And now you're actually participating because you can be very selective in your stock picking and be
John,
more
you say that
successful.
so much better than I do it. I just go, you need to do this.
Well, I've got more.
But you do. That's exactly. And I've said that for a very long time. And James can totally attest to it. Is that when I wake up in the morning and I look at my phone and I look at my holdings that are pre-market, I can tell you what's going on in the world today.
Oh, yeah, I know.
2-year bond yields, 3-month bond yields. That means nothing to the average person that's walking around today.
Right.
I know what the Fed Reserve is looking at as far as hiking rates, lowering rates. I know what your mortgage is going to be worth in 3 months. The world becomes very transparent when you start pulling back that curtain and understanding the wheels that make the plane, the car, right? Everything starts rolling.
And now you're participating and you feel that you have a sense of control and a reduced anxiety. I'm not worried about the market now. It looks terrible. It's just red across the board. I don't care. No. It's going to turn around. It's a great time to buy stock. Yeah. I mean, it is going down. So you don't want to, the quote is, don't try to catch a falling dagger. You could hurt yourself. But I mean, it's probably not a bad time to think about if you have cash on the sidelines that you might want to invest.
Well, so this is exactly what I was just saying to James before we came on, before you caught up with us there, John. 100%. I said to James, I'm like, you looking to invest anything right now? And he's like, well, I've got some travel stuff, that kind of deal. And I said, well, I think the Qs they're gonna tank. So the NASDAQ, I think, is gonna tank over here in the next little while. I think SQQQ, you're gonna short that. You're gonna short the NASDAQ. You're gonna run it. And I think that you're pretty easy because it's a triple leverage ETF. To take 15% over the next month is gonna be, I think, pretty easy. Now, we tell people that they can get a 15% return in a month. They look at you like, yeah, but you know black magic.
Right. This is the problem. This is they have trained us to think that 6% would be amazing. That's nuts, right? It's because they're taking 3, 4, 5%, right? But we can guarantee you 6 to 8%. We'll do you a big favor here because we care about you. Yeah, they don't. Yeah. So they've trained us to be happy and gratified with these incredibly low returns because they have a profit motive and good for them. But this is where having a little bit of education and being informed actually get you in control of your life again and allow you to retire or semi-retire at a very early age and be able to do whatever you want. I can do whatever I want now. I teach because I want to teach. So I'm not going to after this point. Another linchpin thing here. So it's not about money. It's about you and your life and being able to do what you want to do with your life. And you have bought that time because you sacrificed a bit of your time in the present so you would have time in the future. And you're going to need it. So the other thing that's a key point of this too, and it comes from some of my economic training, is this calculation called net present value. So you may have heard about it, Patrick.
Net present value. Okay.
Right. So if you have $100 and it's invested at 6%, in a year it'll be $106. So what you do is the value of that $106 in the present time is $100. So you want to be able to figure out over the period, that money that you invest now, what would it be worth in 10 years now? What is the cost of that grande caramel frappuccino latte that cost you $8? And I would do this at work and drive people crazy. And I would say, okay, you're looked to be about 30 and you just spent $8 on a coffee and you're going to be working for the next 30 years. So I would do what's called a discount rate calculation. And I said, that coffee actually cost you $1,500. And we'll take if you want 70% of your gross income, and we will divide. So that actually cost you could have retired 2 weeks early. But instead, you chose now in the present time to gratify yourself, to have this $8 coffee, ridiculous coffee. You're going to have to work for an extra month or 2 weeks. Now, when you start doing that with all the little things that you buy, or the car you don't need, the expensive car, all these things that you don't need to satisfy your present time gratification, you're going to work for years longer. So I always took my calculator out. I can do it very quickly for anybody. I can say, and it's a factor, right? So I would bring it down to your own personal factor. So I would say you're 30. So any money you spend now, every dollar you spend now is a factor of 30. So you're actually giving, it's actually not costing you dollars, it's costing you $30.
Right.
And your factor is 4 or 40 at your age. And the factor gets lower as you get older because you have less return period. So I would do these net present value calculations. I would turn it into a factor. And I say, think about it. Every time you're spending money on that, it's actually 40 times more. And then you realize, convert that to how much time that you have lost. And now you're working for years and years. And believe me, when you're pushing 60, you're going to regret buying all those stupid lattes when you're in your 30s.
Oh, yeah.
So you have to think about money in the future value of that money and what you're giving up by having that. It doesn't mean you can't have fun, but you just have to be sensible about it and balance your living now and your living in the future.
Yeah.
Well, so yourself, when you're educating and you're seeing a generation of youth that has been kind of brought up with the YOLO mentality,
Yeah, I know.
live once type mentality, where, you know, it's more important to get the pictures of you sitting by the beach than it is, you know, spending the time and
Not
learning.
even sitting by the beach anymore. Now it's sitting with your Frappuccino.
Right.
Yeah.
Simply the Starbucks is street
Yeah.
cred alone, right?
That's street cred now. Yeah.
Yeah. Well, I can go sit by the beach now, and I do.
Right.
Yeah, right.
And
I go
I'm able to
to
do that, to retire early, go sit by the beach. No, I'm not 20 anymore, but those guys, those 20-year-olds who were doing all this and living for the moment are going to be in for a big surprise when they have no money and they're looking at their retirement coming up and they've got a small pension and they were just having a blast in their 20s and 30s. And now they just have to keep working. You see a lot of these people working in retail at Tim Hortons and other places to try to supplement the money that they forfeited 20, 30, 40 years earlier, so that they could live in the moment and get that gratification. At the moment, it's gone.
Right.
You know, it's just.
So where do you, so with the individuals that you're seeing right now that are coming through, like you're dealing with individuals from 20 probably to 30 that are, you know, in your courses and that sort of thing, right? So when you're seeing those people and you have these discussions, in the back of their minds, I'm sure there's a level of, well, my parents are divorced. Each one of them owns a home. I'm going to inherit. I have one other sibling. You know, this generational wealth gapping or trap, as you know, I'm quite concerned that it's going to end up being. What do these folks say in that age demographic when you're realizing that inflation is eating your wealth at 10%? So your $1 million home, you got 10 years of burn.
Yeah, I haven't had that conversation. I have that with students. They definitely have caught onto this YOLO thing, which is a great little piece of propaganda that benefits a certain sector.
Right.
And, you know, and this ridiculous notion that, you know, life is priceless and, you know, you just whip out your credit card and you can satisfy your every desire by using this credit card, you know, and it's worked. A lot of people are now cottoned onto this idea and bought into it, and now sort of really undermine their own financial freedom and their own future by doing this. So as a marketing concept, it's been highly successful. And this YOLO idea is out there, and people, well, it kind of makes sense. I should just enjoy myself while I can. And it's a very immature, childish view of self-gratification at a young age and perpetuating this state of childhood throughout your middle years, your income years, when you should be socking away money, enjoying life, but building your wealth during those high income years that you can just sort of like I did at 55. It's like, I'm out of here. I'm just going to teach part-time, or I'm not going to even do that anymore. And I can do pretty much whatever I want.
Right.
And that is very gratifying. And if you maintain your health by running and doing other things, you can be around for another 30 or 40 years in reasonably good health and be able to enjoy all those things anyways, just as much, really.
Yeah.
I'm in better health now than I was in my 20s and 30s because I actually make a point of it. Right. So you want to be able to leverage your good health and wealth. So if you have a lot of there's something in economics called a utility curve, right? So once you get past the halfway point in life, it's kind of a slippery slope, and but you can do a lot to change the angle of that curve and change the end point of that curve. Like you can live longer, but not only do you live longer, but the quality of your life improves. So this idea of doing net present value calculation and understanding the real cost of your money, combined with staying healthy, increasing your lifespan, and increasing the quality of your life, go together beautifully. You can really try to flatten out that curve. Now it's inevitable, but you can live long, healthy years with your own time, financially independent.
Yeah.
It's not even that hard to do. It's so simple.
You are exactly preaching what the profiteers, Pat and I, say daily. You have to heal your mind, body, and soul, and your money. You got to do all four. You have to have a strong, solid mind. You have to have a strong body, so you have to work out, and a good soul. And you have to worry about your money. You really have to be focused and present. And this whole idea of going on vacation on credit, or doing all these things on credit, like you're saying, is a really bad idea, because you're always back, you're always behind, you're always trying to catch up. I lived that way for a very long time, and now I'm the other way. Like this trip I'm about to go on, it's paid for. It's not credit. It's paid for. It's done. Right. Because I've built that income through the things that Pat has shown me.
Yeah, exactly.
And I'm healthy, so now I can go travel. I'm 52, almost 53. I'm probably healthier than a lot of the people that will be in Portugal with me. I'm light. I can run. I can do. I'll be able to do everything there is to do, and I can do all this because I've taken care of my mind. I've taken care of my body. I've taken care of my soul, and like Pat's taught me, I've taken care of my money. And I think all of those things are important. And it's nice to hear someone else say it besides us, right, Pat?
Well, yeah, we just keep flogging the dog, so it's nice to get somebody else to come in here that has a bit of a basis in it and has done it. Again, what we're doing right now is we're aiming at the board and taking shots. And John, you've went through it and you've had those successes, and you've hit the bullseye where you're able to step back and go, I now work because that's self-gratifying for myself, my family, and I'm able to give back and help young people. And I think that's fantastic what you're doing. And we're just over that hour mark, John. So I think what we'll do is we'll leave it at there for tonight. I think, John, that we could sit and talk for hours, and we'll have to do this over a beer sometime. But we'll leave it at that for tonight. So, John, again, thank you so much for joining us. I appreciate your viewpoint on this, and I'm sure that your students find you fascinating. And obviously, you've got a wealth of knowledge from the healthcare system all the way down to simple facets of what makes a good life at the end of the day.
Right.
When you're talking about the things that you're talking about, there's a lot of things that people can take from that. So all the profiteers out there, guys, check out my last video there in regards to kind of learning some of the basics when we're talking about charting and the RSI, your MACD indicators, that sort of thing. Listen to this guy. John is explaining to you from a guy that's been through this, a man who's done this, that it is not super complicated. It's just an education, right? You want to learn how to cook? You take a class. You want to learn how to do this? I'm not even asking you to take a class. It's a couple videos. Throw it on in the morning. Throw it on when you're heading out the door. Throw it on the car. This is very passive. But if you don't do it, there's going to be a big expense for your $8 macchiato. That's all I'm saying. At the end of the day, guys, thank you so much for joining us, and let's make some money together.
So, John, normally what we do at the end, which is Pat's already jumped the gun a little bit here. We say our little spiel. And then at the end, we say our little sign off. Obviously, Pat says, let's make some money together. So Pat went, and then it'll be me, and then it'll be you, and you can say whatever bit of wisdom you want to say. So profiteers out there, I think we got some amazing information from John here. It was kind of gratifying to hear, like the whole thing where John was saying, if you understand money and markets, you understand politics, you understand. Pat has said literally those things while showing us how the charting works. And he showed us the charting and said, because of the politics, we know this is going to happen. And it's not as complicated as you think. Coming from a guy who knew nothing about money about 3 years ago. I learned all this slowly from Pat. He's a great teacher. There are lots of target-rich videos. Some of them were cartoons. Some of them were just sitting under a chart. And the last one he just did with a young lady, Sarah, is quite amazing, and it really breaks it down because he's helping one of our profiteers actually learn about this. And I think it would do you a world of good to see that. Coming up shortly, I'll be heading off to Portugal. In fact, the next Thursday night live, I'll be in Portugal, and I don't know if I'll be sober. I don't know. We'll see. We'll see. It could be a fun show on next Thursday. So you may want to see it. Hi, babe. How you doing? But the reason I'm going to Portugal, and I say this out loud to anyone who'll listen, is because the man right here. Because I listened to him and I earned money. I couldn't travel before this. I was living paycheck to paycheck. Yeah. I was hand to mouth, as it were. I get the money and put it in my mouth. I've learned so much from this man, and because of it, now I can travel. Now I have the fortitude that I can take time and I can run and I can look this amazing because I'm a sex god. I have the mind of a sex god because I think I'm a sex god, and a lot of that has to do with the financial freedom. And if we take the time, John's told you now, Pat's told you now. I don't know how many more people we got to get on here to tell you, but we're going to keep on trying. John, you have been fantastic. I knew you would be. You're just the talks we've had while we were running. You're a very, very highly intelligent man, and the way you break down things and decode things. I had no idea about all your wealth of knowledge in the hospital system. That was very super interesting stuff. I now understand more why my doctor takes more time off than you. We should be probably nicer to our doctors, now that we know what they're going through a little bit here. So profiteers out there, I want you to get out there, get your goals. Listen, work on your money. Stop buying those macchiatos. Save some money. Start buying some NASDAQ, apparently. Listen to this guy. Let's heal our minds.
Don't buy it. Short it. Don't buy it.
Yeah. Right. If you can short, you're short. Yeah.
Short it. Yeah. See, I don't know everything yet. I'm still learning. Go ahead, John. You're up.
Oh, I'm up. Okay. So from what we ended up talking about money, but it's not really money what we're talking about. It's talking about the quality of your life and your ability to gauge life and achieve your potential in your life. So we don't want to be fixated because we're not Scrooge McDuck and we just want to accumulate these huge amounts of money to stare at. It's not. It frees you up to achieve your potential in your life, to travel around and do the things that you love to do. You don't have to travel. You can have these other hobbies or just do nothing if you want. If you want to sit around and read books, whatever that is for you, you now have the choice to be able to do it because you've gained control of your life. So the sort of the one key thing is the most precious thing you can have is time, because with enough time you can do everything. With no time you can do nothing. So it's always to your advantage to extend the amount of time that you have, and not only just having time. If you are suffering during that time, if you have a long life and you have no money and you're living in near poverty, that is not quality time. That does not have to happen. So you can extend through good health practices the end point of your life, and you can also improve the quality of your health and the quality of your life. It's within your control to do that, as you found out, James.
I did. Absolutely.
Well, John, thank you again for joining us.